Hi, Dr. McCarthy. This is Tony. Thank you so much again for letting me do this presentation via YouTube. It has helped us very much as we were going through our move. If you have any questions about this presentation, feel free to email me. I'll get back to you as soon as I can. Thank you so much. Okay, so why don't we get started? Sam Green is a 57-year-old Caucasian male, comes to the ER presenting with severe abdominal pain and cramping in the lower left abdomen of 2-week duration. He describes the pain as a constant pain that radiates down his left leg. He says the pain is sometimes accompanied by an occasional wave of cramping. He says the pain is made worse upon standing or attempting to walk, and he finds some comfort in sitting or lying very still. He has tried Tylenol and ibuprofen for the pain, but has not seemed to have helped much. The pain does not seem to change in character or severity with respect to diet nor time of day. The pain has been progressively worsening, however, particularly in the last 2 to 3 days. The patient claims to have felt this pain on his right side before, after which he was diagnosed with colon cancer. The patient conveys that the pain is so severe that he has not been able to do much of anything. He reports being queasy at times, particularly when the pain is severe. He reports a decrease in appetite, citing discomfort and pain, and this has resulted in a loss of 7 pounds in the past week alone. However, he reports no vomiting or constipation. He has, however, had 3 to 5 bowel movements of loosely formed stools ever since he started chemotherapy 4 years ago. However, in the past few weeks, he has noticed more episodes of these loose stools. He, however, has not noticed any blood in the stools and states that his stools are usually fairly dark. He also believes he has a low-grade fever, though he denies having traveled recently. He also experienced fatigue in the past few weeks, but thinks this is due to the abdominal pain keeping him up at night. As for past medical history, allergies include penicillins and possibly soma. Currently, he's taking a daily aspirin tablet, a daily multivitamin tablet, Tylenol and ibuprofen as needed for the abdominal pain, antihistamines as needed for allergies. He also took 5-fluorouracil and levamisole for colon cancer, but the last dose was administered 4 years ago. Past illnesses include, of course, the colon cancer, which is believed to be in remission and is monitored biannually by an oncologist. He reported no abdominal trauma. As for surgeries, there was a resection of part of his colon and small intestine to cure the colon cancer. Also, an infusion of the infusoport to deliver chemotherapy was undertaken. His immunizations are up to date with the yearly flu shots and tetanus boosters 6 years ago. As for family history, his father had congestive heart failure and atherosclerosis and died at the age of 66. Family history was otherwise unremarkable. As for social history, he quit smoking 12 years ago, though the number of pack years is not known. Alcohol, he has beer on occasion. He denies any use of recreational drugs. He denies any past STDs. He also is in a monogamous relationship with his wife of 22 years. They have 4 children, all of whom are healthy. He has worked as a policy analyst at a large insurance firm for the past 17 years. He has made several attempts to increase fiber in his diet, but also enjoys popcorn on a very regular basis. He is also moderately active. He is a Catholic of Swedish descent. For review of systems, he denies any chills, night sweats, no changes in any of his 5 senses, no headaches, no oral ulcers, no chest pain, no arrhythmia was reported. He reports no cough, no asthma, no wheezing, no bronchitis. He describes no dysuria, no hematuria, no changes in urinary frequency, no changes in urinary frequency, urgency, or retention, and no sexual dysfunction. He describes no pain in the muscles of joints. He has no sensory loss, no or transient symptoms like numbness or weakness or visual problems. He notes no redness, cyanosis, jaundice, or flushing, and he reports no anxiety or depression about worrying about his current condition. For the physical exam, his blood pressure is 120/80, heart rate 60, which was rechecked and showed 85, temperature is 98.6, respiratory rate 16, height 71, weight 210 with a BMI of 29.3. General appearance is alert and oriented ×4, though in slight distress. As for the HEENT, pupils are equally round and reactive to light and accommodation. Extraocular muscles are intact bilaterally. Ophthalmoscopic examination revealed a positive right positive red reflex with no retinal hemorrhages. Tympanic membranes were intact bilaterally with a positive light reflex. Moist mucous membranes were noted. No oral ulcers or cracks were noted. There was no thyromegaly, and a cardio exam revealed a regular rate with a slight sinus arrhythmia. No murmurs, rubs, or gallops. No carotid or abdominal bruits were noted. Posterior tibial pulses were 3 plus out of 4, and a slight bulge in the upper right chest was noted, but this is due to his implantation of the infusive port. Respiratory exam. Lungs were clear to auscultation bilaterally. No rales, rhonchi, or wheezes. Abdominal exam. Positive bowel sounds were normal in all 4 quadrants. There was a slight tenderness upon palpation in the left upper quadrant, with very obvious tenderness upon palpation in the left lower quadrant. A fullness was also noted in the very same quadrant. Tympanic sounds were noted in the left upper quadrant, left lower quadrant, and the right lower quadrant, with normal liver dullness in the right upper quadrant. Straight leg testing of his right leg caused some discomfort in his abdomen, whereas straight leg testing of his left leg caused severe pain and discomfort in his abdomen. Rectal exam demonstrated no prostatic hypertrophy or nodules. GU exam, there was no CVA tenderness, no inguinal masses or hernias, and no testicular masses. Musculoskeletal exam, no redness or cyanosis. Normal range of motion in both passive and active in his hips bilaterally. There was no pain upon palpation of his hips bilaterally. However, lumbar lordosis and thoracic kyphosis of his spine was noted. No thickening or masses over the spinous processes. Neurological exam, cranial nerves 2 through 12 were grossly intact. Biceps, triceps, and Achilles tendon reflexes were 2 plus bilaterally. Patellar reflexes were 3 plus bilaterally. Sensation was intact in the periphery. As for labs and imaging, the occult blood test was negative. CBC demonstrated an elevated WBC count of 12,200 with an accompanying neutrophilia of 81.6%. RBC was slightly depressed at 4.64 million. Hemoglobin and hematocrit were both depressed at 12.5 grams per deciliter and 37.9% respectively. Peripheral blood smear, however, was normal. Ferritin and other iron studies, including serum iron, total iron binding capacity, and iron saturation, were all within normal limits. ESR was also within normal limits. Bacterial blood cultures was negative, as was bacterial stool cultures. LDH was also within normal limits. Other liver function tests, including albumin, alkaline phosphatase, AST, ALT, GGT, bilirubin, were all within normal limits. Routine urinalysis was unremarkable. A CEA was performed and was within the normal lab limits. However, a previous baseline was not available for comparison. Barium enema was unremarkable and demonstrated normal patency. An abdominal CT, however, demonstrated two findings. One, the left sciatic nerve was shown to be closely associated with an enlarged hypertrophic piriformis muscle, and also active diverticulitis was also seen in the abdominal CT.